The first talk is about unraveling the causes of red eye. Dr. Neethu, who is consultant at Giridhar Eye Institute, Kochi, will be talking on unraveling the causes of red eye.
So, very good morning to one and all. So, I'll be talking on red eye, unraveling the causes. So, before going into the details of scleral inflammation, let's talk a little bit about the anatomy. So, sclera, it's a dense connective tissue enclosing 5/6 of the eye, maintains the shape of the globe and the intraocular pressure. It's where the extraocular muscles are attached, and it protects the intraocular structures from trivial trauma. Coming to the anatomy, it is thinnest at the rectus muscle insertion, 0.3 millimeter, and thickest near the optic nerve. It has got two foramina, the anterior sclerocorneal junction, which is 1.5 to 2 millimeter wide, and the posterior. Now, the left picture shows the scleral fiber merging with the cornea, and the right one shows the posterior part of the sclera forming the lamina cribrosa, which has these foraminas, which allows the entry of the central retinal artery, vein, and the optic nerve. Now, it's very important to know the layers of the sclera. The topmost is the thin connective tissue, which is highly vascular, the episclera, which is abundant in collagen, fibroblasts, proteoglycans, glycoproteins, and melanocytes. The next is the scleral stroma, which is rich in collagen, elastin, fibroblast, and melanocytes. And the innermost is the lamina fusca, which contains the melanocytes predominantly and collagen and elastin. And this fusca got these grooves, which allows the entry of the arteries. Now, sclera is an avascular structure with low metabolic rate. However, it receives its blood supply from the topmost episclera, which is supplied by the anterior ciliary arteries and posterior ciliary arteries, which forms the superficial and the deep episcleral plexus. And it's a highly sensory innervation. It is innervated by the posterior ciliary nerves. So this is very important to know because in any case of mild scleral inflammation, the patient will have excruciating pain. Coming to the classification, it is classified predominantly as episcleritis and scleritis, and we follow this Watson and Hare classification. Now, this is a montage which shows a classification of sclera. The anterior means it is anterior to the insertion of the recti muscle, and posterior means posterior to the recti muscle insertion and posterior to the ora serrata. And we have the infectious and the non-infectious. And in the non-infectious type, we have the depending on the presentation, like diffuse, nodular, and necrotizing, which we have with inflammation and without inflammation. Now, coming to episcleritis is a benign inflammation of the episcleral tissue, self-limiting disease, recurrent in nature, usually affects women, bilateral in 40% cases. Etiology is idiopathic, can be associated rarely with systemic disease like herpes zoster, rosacea, gout, syphilis, and atopy. Symptoms, patient can present with mild discomfort, irritation, redness, and precipitating factors are emotional stress, menstruation, ovulation, exposure to airborne allergens, occupational, seasonal, perennial, and allergic to food products. Now, this is a patient who presented with episcleritis. As you can see, there is episcleral congestion, and this is a diffuse form. And here you can see a nodular episcleritis. And one thing to keep in mind is that the patient with episcleritis never causes vision loss or corneal involvement. So it's a benign and self-limiting disease. Now, a look-alike condition, like what you see in this picture, it's a corkscrew conjunctival vessels. So when in confusion, because most of these vessels you can see in carotid cavernous fistula, so when you see these vessels, when you are in doubt, it's better to put a drop of T plus phenylephrine. And in episcleritis, the vessels blanches with T plus. Scleritis, the incidence is 3 to 4 per 100,000 and prevalence is 5 per 100,000. Females are more affected, 4 to 6 decades in age, and most commonly is anterior, non-necrotizing, and non-infectious. Infectious scleritis comprises of only 5 to 10%. Now, when you see a case of scleritis, the commonest disease that should come into your mind is autoimmune diseases, rheumatoid arthritis, granulomatosis with polyangiitis, which is otherwise known as the vaginous granulomatosis, relapsing polychondritis, SLE, inflammatory bowel disease, polyarteritis nodosa. And infectious, you have to think of tuberculosis, syphilis, Hansen's, herpes zoster, and fungi. This is a picture showing the systemic association in autoimmune disease, rheumatoid arthritis, the small joint involvement, relapsing polychondritis, the thickened pinna, herpes zoster, the vesicle lesions, and Hansen's disease with hand and foot deformities and saddle nose deformity. Now, it's very important to have a detailed history in case of scleritis. So, history of trauma, ocular surgery. So, trauma more point towards infectious etiology. Ocular surgeries, there is something known as surgically induced necrotizing scleritis, which you see in mostly in post-tertium surgery due to excessive cautery. Occupational also some occupation can be related to infectious etiology. Now, a history of headache. In infectious scleritis, I think patient mostly complains of severe headache, and also history of immunosuppression. Diabetes points more towards infectious etiology, and small joint pain, skin diseases, more of autoimmune, and also you have to take a detailed history of the drug intake. Symptoms: unilateral, bilateral, recurrent. Yeah, the patient may complain of dull pain, tenderness, and the pain radiating to the neck, jaw, face, and cheek. And redness of violaceous hue can be noted in autoimmune scleritis. And decreased vision is noted when there is corneal and retinal involvement. This is a young male who presented to us with nodular scleritis bilateral. We extensively investigated this patient, but everything was turned out to be negative. But this was highly resistant to treatment. We started on oral treatment. The patient was not at all responding. So then we had to pulse him. And after pulse, I think he improved a little bit. And he also gave a history of otitis media. So we again thought of revisiting our diagnosis. We again repeated the ANCA, and his anti-MPO was positive. He was treated with injection rituximab. This is the down picture shows the response to the treatment. ANCA positive patients had no prior immune mediated disease, and the vasculitis was diagnosed because of the scleritis. And there is a higher need of multiple immunosuppressive therapies in ANCA patients. Now, ANCA associated can also have corneal involvement. This is one patient with thinning with vascularization, and more of keratopathy, corneal infiltrates, thinning, ulcerations, and more vascular pannus is noted in ANCA. Now, this is another patient with bilateral scleritis, localized scleritis. So we even extensively investigated. We never thought of Behçet's initially, but then when it comes to a diffuse nodular scleritis, more resistant, unresponsive to treatment, Behçet's is a possibility. When you come across such cases, it's better to do HLA-B51 testing, and also early use of strong immunosuppressive therapy is recommended in these patients, and you need 2 to 3 systemic immunosuppression. This patient actually failed with triple IMT, and we had to pulse and give cyclophosphamide. And this is a 13-year-old boy with recurrent episodes of limbal nodule at the same site. Same site, it was in the inferior side. So when it comes to scleritis or episcleritis, you see the nodules mostly in the temporal or the nasal side. But this patient had an inferior side without any pain. So it was recurring. While using the topical steroids, it goes off and then comes back again. And he had a high absolute eosinophil count. We did a biopsy, and it was a trematode infestation. This is a zoster-associated scleritis. You can see the vesicles in this picture, and you see the patient complained of pain after 2 months. So we were wondering, just like that, if you see there is no congestion, but when you retract the lid and see there is a nodular scleritis sitting there. So a thorough examination of the sclera is always mandatory, and you have to start these patients on antiviral again and oral steroids or topical steroids. This was a very tricky patient who was diagnosed as autoimmune scleritis. His ANA was positive, ANCA was positive, and he was started elsewhere on immunosuppressive therapy when he came to us. And you see this nodule, this was not looking so great, but still we didn't have any second thought, so we thought it could be only autoimmune. But then on follow-up, his nodule is increasing in size. So this had a yellowish hue. So then we did a scleral debridement, and there was a fungal growth. Fungus acremonium is noted in this patient. He is now doing well with antifungals. Posterior scleritis comprises only of 5% of total scleritis, and this was one of a patient with a giant nodular scleritis. You can see the choroidal folds here. OCT showing the choroidal folds along with the choroidal mass. You may get exudative retinal detachment in these patients, and B scan confirming the T sign, and also it can be isolated, or even you can have anterior scleritis or nodular episcleritis as you see in this patient. This is congenital erythropoietic porphyria. So as you know, it's a genetic disorder, autosomal recessive, and you have severe necrotizing scleritis in these patients. And as you can see, a patch graft was done elsewhere, and this patient had recurrent uveitis following the graft, and it was found to be infective. As you can see in this picture, this was a corneal infiltrate and a hypopyon. Now, scleritis rarely occurs with ankle closure attack, and this patient had a coelochoroidal effusion and a posterior scleritis, along with diffuse anterior scleritis and chemosis, and this patient was RA positive. Now, not only frank scleritis, I think you need to look into the adjacent structures. Sometimes dacroadenitis can cause scleritis. Meibomian gland dysfunction, as you see in this patient, they see the lid margins. So this is severe meibomian gland dysfunction related marginal keratitis with thinning of the peripheral cornea. Once you treat this condition, the scleral congestion also comes down. Now, this is one patient with syphilis who rarely presented with scleritis alone, and he came to us with scleritis, and then we diagnosed syphilis. So the great mimicker even can present as scleritis, so beware, and it is better to add RPR TPHA to your scleritis panel. Conjunctival ulceration, this patient had a conjunctival ulceration with uveitis. The MANTO was highly positive, QTP positive, HRCT suggestive of Alcock sequelae, and the TB was diagnosed. So my take-home message is that suspect infectious etiology when there is history of trauma, surgery, nodules with pus point, multifocal, ulcerated conjunctiva, underlying yellowish hue, and also corneal involvement. Non-infectious, you have the localized or diffuse bluish hue, nodular, large, firm or immobile nodules, and also evidence of past episodes, bluish hue and areas of thinning, bilateral and improves with corticosteroids. With that, I wind up my talk. Thank you.
Thank you, Neethu, for that very informative talk.